Uh, so
Audio.
we're gonna be talking about rethinking spine surgery,
No, unmute.
a robotic odyssey. I'm
Hey.
Anissipour, I'm an orthopedic spine surgeon up in Everett in private practice. I've got a mixed degenerative and deformity practice. I did my fellowship at University of Washington and Harborview Medical Center, just right here in Seattle. Excellent fellowship, uh, a lot of complex spine, a lot of open posterior-based approaches and open spine surgery. And so I left my fellowship feeling like I could instrument the entire spine with proficiency, and I was not afraid of taking care of complex spine cases. I made a commitment to myself that when I start practice, I want to be technically the best spine surgeon I could be for my patients, and I want to start adopting more minimally invasive techniques and add them to the foundation that I learned in fellowship to enhance my patient outcomes. So I set off on a quest to start learning more minimally invasive techniques and advance my skills in spine surgery, in particular in MIS. And this included learning OLIF and lateral spine surgery. And then I began doing L5S1 OLIF, and I started doing my own approaches there, converting it essentially to a lateral ALIF with my own approaches. I started doing percutaneous screws. I started applying cortical screws to my cases. I started doing tubular decompressions, became proficient at motion preservation. And then I started taking all these techniques and applying them to more complex cases and applying them to deformity. And so, like, an example is the case here on the right, where this was done, with OLIFs in front and percutaneously in the back. So I started enhancing my skills and becoming more proficient in using MIS for more complex cases. And then became the question of robotics. And like many of us, I was initially skeptical about the role of robotics in our field. And today I want to take you through my personal odyssey, a transformation in thinking, and a learning curve filled with challenges and invaluable pearls of wisdom gained from embracing robotics, artificial intelligence, and advanced pre-op planning. I vividly recall the days when the idea of integrating robotics into MIS surgery seemed more like science fiction than a viable reality. However, as we all know, the landscape of our profession is ever evolving, and adapting to change is not only a choice, but a necessity. So I'll share the moments that led me to embrace this change, the hurdles I faced during the learning curve, and some of the pearls of my practice that emerged from this journey. Some of the known challenges in MIS and deformity. For me personally, I was doing a high volume of cases. I was doing a lot of it MIS, and the radiation exposure was very concerning. Um, I had a pretty darn high accuracy of screw placement, but as some studies show, we all seem to overestimate our own accuracy. Um, Predicting the alignment parameters with MIS, especially in deformity, can be challenging. Passing of rods is challenging, and assessing abnormal anatomy. The cases we tend to underestimate how many dysplastic pedicles we encounter in deformity cases where there's rotation. Percutaneously placing those screws under fluoro can be increasingly challenging. And when you have more deformed degenerative scoli cases where you get eroded vertebral bodies, all of these make for placing screws with traditional fluoroscopic percutaneous techniques more difficult. And we have studies that are showing that reduced likelihood of reoperation due to malpositioned hardware and the associated costs with it. In some studies, as high as 8.8%. So it's essential to acknowledge that skepticism is a natural response to the introduction of groundbreaking technologies. And the question lingered, would robotics truly enhance our practice, or were we on the verge of just an unnecessary complexity? However, in the face of these doubts, I began to see the potential benefits that could redefine my approach to MIS surgery. The turning point came when I recognized the need to explore avenues for improvement, the promise of increased precision, reduced invasiveness, reducing radiation exposure for myself and improving my patient outcomes. And all of this was too compelling to ignore. And that marked the beginning of this journey for me that would challenge my preconceptions and ultimately transform the way I've approached my craft. So as we navigate through this section, consider your own moments of hesitation and reflect on the catalyst that pushed you towards embracing change. Here is an example of a case. This is a 33-year-old female, severe worsening low back pain, a foot drop in radiculopathy, L5 radiculopathy. She's got a grade 3, borderline grade 4 isthmic spondylolisthesis. And the CT on the scan, which I may not have recognized had I not gotten a CT ahead of time. And if I just tried to place this with fluoroscopic screws, you could see that L5 pedicle is really darn narrow and that foramen's riding high. And it could be very, very easy to injure that nerve root trying to place that fluoroscopically unless it's right on. And so I now attack these cases with a lot of anterior exposures. I'll do my own L5S1 approach, mobilize the vertebral body, open it up here. And then as I do so, I'll place an L5S1 Olive cage. In this particular case, I put it in with a washer as a buttress so that I could still reduce that spondy. And then I used the robot to place these screws percutaneously and then reduce off of that to get a nice reduction. And in doing so, you can see this pre-op and post-op MRI, not only showing that it's reduced, but more importantly, the L5S1 foramen, which was severely narrowed, indirectly decompresses on the image on the right, and you can see that nerve root free with a kind of a final post-op X-ray here. So, being able to attack cases like this with less invasive techniques is the big draw for me. And it was not all easy, though. Entering the realm of robotics and spine surgery, my first and foremost concern was that initially during my learning curve, I seemed to be misplacing pedicle screws. And this is a deviation from the precision I was accustomed to with fluoroscopically assisted perc screws or traditional open screws. The initial inaccuracy raised the critical question for me. Was this journey I'm trying to embark upon worth the potential harm to my patients? And in the face of this challenge, I embarked on a journey of reflection and discovery. I worked to identify the causes of these misplaced screws. And today I share with you the insights I gained during this process. The factors contributing to misplaced screws were multifaceted. Patient shifting inadvertently, either me or my PA leaning on the table and sort of shifting the patient, anesthesia nuances, inadequate depth of sedation, and the patient moving or coughing and kind of shifting a little bit. These all played a crucial role. Another factor is emphasizing a light touch technique, which was pivotal. The robot's designed to accurately put your intended trajectory into space, but with forceful techniques, you can compromise and cause deviations from that. Fixating the robot to the patient, I think, is critical. And we usually do that with a PSIS pin, and that emerged as a crucial part of the practice. Fast forward today, and the rate of misplaced screws has significantly diminished, and it's now approaching what I'd consider extremely rare. And the launch of the navigated Midas proved transformative, notably reducing skiving. I think this was probably the most critical technology that helped with reducing the misplaced screws, because we use that Midas to precisely, cannulate right down the pedicle and eliminate any potential pushing and deflecting with a drill or probe. Other pearls of this practice, amidst the challenges of this learning curve, several pearls emerged. In open surgeries using robotics, careful consideration of the screw trajectory is paramount. Highly convergent pedicle screw angles during open surgery can lead to the fascia pushing medially and potentially kind of deviating the aiming arm to cause a medial breach. And to mitigate this, I tend to plan less convergent screws trajectories or placing the screws a little more laterally to avoid pressure from the fascia on the robot's aiming arm. Or an additional technique is in an open surgery, I may incise the skin and retract the skin out, but I'll actually leave the fascia more medial and come through the multifidus and fascia to enter and kind of do a semi-perk approach through fascia so that the fascia is not actually putting any pressure on the aiming arm. Now, contrast this more vertical trajectory with a percutaneously placed screw. In these screws, I tend to favor a more convergent outside-in trajectory, and this approach targets the notch between the facet and the transverse process, reducing the risk of skiving off the facet. These nuanced adjustments in technique and trajectory have been transformative, offering a deeper understanding of the interplay between robotics and surgical precision. And as we navigate the complexities of integrating technology into our practice, these pearls enhance outcomes and patient safety. So the integration of advanced software and tools stands as a beacon of progress. It reshapes the landscape of our practice. And today I want to shed light on some of these new transformations. In particular, I want to focus on facet decortication, which is an integral component of the surgical arsenal. I'm going to try to play this slide here. There we go. Navigation software. At the core of precision lies sophisticated navigation software. Witness this video here where 3D guidance allows us to navigate the spinal anatomy with accuracy. And these tools serve as a navigational compass, ensuring that facet decortication can be executed meticulously. It allows us to visualize the tools and enhance the clarity during facet decortication, and the high resolution imaging systems integrated into the surgical microscope or display act as a visual guide, distinguishing critical anatomic details, and allow for accurate facet decortication to be done percutaneously. So just identifying right here kind of the graft delivery after decortication that we deploy. We're usually just placing some ground up autograft with some DBM into the facet and packing it in. So I've been utilizing that facet decortication in my cases, especially in my MIS cases. And as we are seeing more technological innovation in spine surgery, I see more exciting possibilities that are beyond our current capabilities, but hopefully on the horizon. My hypothesis is that facet decortication under image guidance is the catalyst for future advancements in spine. Number one, I think the next step for us would be incorporating osteotomies. Building on the foundation laid by facet decortication, the logical progression leads us to consider that incorporating osteotomies under enhanced image guidance. Imagine a landscape where precision meets versatility and allows us to tailor osteotomies with unprecedented accuracy. This evolution could redefine our approach to complex spinal deformities and offer tailored solutions to each patient's anatomy. Beyond osteotomies, and looking further ahead, I envision utilizing this technology to facilitate decompressions. This could be the next step in our frontier. Image-guided technologies refined through lessons learned from facet decortication may pave the way for minimally invasive decompressive techniques. This not only addresses the root cause of spinal issues, but does so with a level of precision that was once deemed aspirational. Also, beyond individual procedures, the future holds promise of holistic, patient-centric approaches. Integrating robotics, AI, and advanced imaging could enable personalized treatment plans tailored to each patient's unique anatomy and pathology. This shift forward of individualized care marks a big change in how we could approach spine surgeries, emphasizing not only procedural precision, but also the overall well-being and recovery of our patients aided by AI. In this envisioned future, the journey doesn't end with technological milestones, but extends into the realm of patient outcomes that are maximized and the art of spine surgery is elevated to new heights. While we navigate the present with facet decortication, the future beacons us towards innovation and redefines what the boundaries might be, boundaries of what is achievable in MIS surgery. As we venture forward, the synergy between tech and surgical expertise continues to unfold, promising a future where precision, innovation, and a patient-centric care converge seamlessly. That's been my path towards incorporating robotics into my practice, and now I find to be paramount as a part of my normal routine practice. And I was happy to share it with you today, but I'm excited for what the future holds with us for us. Thank you guys for inviting me, and thanks for your time.
Ollie, it's Pat Johnson. What a inspiring talk. Where you come from and where you train and all that, and you decided you're going to turn yourself into a MIS surgeon. I mean, I'm kind of curious how you got yourself into MIS surgery. I mean, did you go visit people? I mean, you didn't do it in your training, so I'm just trying to understand it. I admire that a lot, and I'm just wondering, how did you do it? Or did you just decided, I'm going to do this? I'm going to figure out how to do it. You must have had a few steps along the way because, you're a young, innovative guy, and I'm impressed. Tell me a little more of your story, or everybody here. I'm curious.
Yeah, thank you. I think it starts with, for me, learning a foundation of being comfortable with proper spinal techniques and learning to instrument the spine was paramount. And learning that open for me was really, really important. But then the most critical step for me was a commitment. And it was a commitment that this is what I want to do, and I need a stepwise approach to do it. And it starts with kind of penciling out an outline or a plan. And so I started with going to courses and saying, right now I'm going to focus on developing decompressions. And so I'll start by graduating towards a tubular decompression. And that may mean that you start by doing a little open like an open approach, and then putting a tube right over the anatomy. And as you're doing your hemi-lami or your microdiscectomy, doing it through a tube for practice until you can start to take that open exposure away and decompress through a tube, and start with a hemi-lami, then train yourself to start going across and drilling across and doing a bilateral lami through a unilateral approach. It's just a stepwise approach of building on your own skill set. That's for decompressions. For perc screws, I got some of that in my residency training, but again, in courses on cadaver labs. Same thing with the OLIF. It was a commitment that I wanted to learn the OLIF technique. I went to enough courses. I practiced on cadavers. I picked easy cases. And as I developed a mastery of that technique, I decided that I'm going to teach myself how to do my L5S1 approaches. And again, this is with, committing to something, preparing ahead of time, preparing for where complications can be met, and practicing. And with the L5S1 approach, it was, I brought the vascular surgeon in the room with me over and over again and said, each time I want to do a little more of this exposure while you're just standing here. And I did that until I felt, and the vascular surgeon felt very comfortable dismissing himself, and I took over. And now I teach that technique to other vascular surgeons. So all of this is just there's a little bit of faith in yourself, but a little bit of a very pragmatic, focused approach to, and a commitment to what I'm trying to do.
Well, you have similarity to one of my fellows who's in Ohio, kind of the same path trajectory into the same. He taught himself how to do things that he didn't learn during our fellowship, which we obviously do them years later. But anyway, congratulations for your, your focus and expertise. It is.
Thank you. Appreciate that.